Welcome to our first Friday webinar in June. I'm Jen Starks. I'm the Business Development Manager here at All Things Neuro, and we started this webinar a couple months ago. I noticed that there was a lot of misinformation out there on neurotrauma, and there's just so many different angles to tackle it from the legal side, from the medical side, and I'm grateful to know people across the country who are experts in different areas, and our goal is to bring them into this space so that you can learn, we can learn together, and you can get some questions answered and participate in whatever capacity you can. So we're going to go ahead and get started. And before we do, I wanted to introduce Drew with Harvard MedTech. They're our sponsor this month. We're very grateful for their support, and I'm going to turn it over to you, Drew. You're muted.
Okay, I think I'm good. It kept muting on its own. I apologize. I apologize. Well, to start over, thank you, Jen. I appreciate it. And thank you so much for the opportunity to be a sponsor of this Friday's webinar. So, Jen and I have known each other for quite a while. I've been in the industry for about 15 years now. And Harvard MedTech is something that presented itself to me a couple of years that has been incredibly impactful in my landscape. I'm primarily in Michigan, but looking to roll out into other states focused on personal injury. And what Harvard MedTech is a treatment solution in the virtual reality realm to help tackle not only pain and symptomology, but also mental health recourse due to a traumatic incident like a motor vehicle accident. So working with PTSD, depression, so on. So it's really been a game changer in my world and my footprint, and I'm just appreciative to help roll it out and network and be a part of certain organizations like yourself. So thanks again, Jen.
Jen, you're muted.
Classic. I was just trying to reflect that, the suspense of what I'm saying is just like Drew. We're like, what's happening now? I was just saying that I'm grateful for their sponsorship. And if you know anyone who is also looking to spread their company's branding across the country, would love to speak with them so that they can also sponsor and be a part of what we're doing. So before we introduce the speaker, I just want to share a little bit about all things neuro. We are also known as Neuro 360 in states outside of Georgia and Ohio, but ultimately we are the same company. So All Things Neuro is several companies that have high-level specialists that combine their expertise to be a comprehensive solution. So our goal is to be able to take them from the evaluation stage to the testing, the treatment, and make sure it's seamless and there's a continuity of care so that the patients can get all the needs that they have on the neurological side. We started this company because we noticed that there were so many patients and clients that were being overlooked, and that this is an issue where if the care is not there and if the education is not around to help detect early signs of neurological issues, then unfortunately people get left behind. And our goal is to be able to walk them through it from right at the beginning of their stages all the way through so that they can get the best recovery possible. So we have a big slew of specialties that we offer. The brain is very complex, so we can take it from a traumatic brain injury to the pain. We work with the pediatric side of brain injuries. We offer therapies for trauma related associated with PTSD to the rehabilitation for those who've gotten the neurodysfunction and symptomology showing that they need to get recovered, as well as the acute behavioral health side. So we can treat anxiety, depression, and other well-being aspects to the recovery. So basically in our services, we have the testing side where we use 300 points of information across 5 different platforms to show them exactly what's happening. We also offer a telehealth side. So if they are not in local vicinity, we're able to do that across the country. That's the same as telehealth as well. So we are very comprehensive on that side for the psych centers. We have our rehabilitation side for concussion with United Neurology in Ohio and Georgia. And then on the post-care services, we can offer a slew of services from IMEs to impairment ratings, life care plans, and forensic analysis. Even if we cannot treat them, we can offer certain documentation that can help show long-term what's going to be going on. So this is my information. We'll check back in with that later. I want to turn it over to our speaker, Dr. Hertza. And just to give you a little bit of information about Dr. Hertza, he's a board certified neuropsychologist and medical director of neuropsych centers. With over 15 years on faculty at the Medical College of Georgia, he brings deep expertise in trauma, TBI, and forensic neuropsychology. He leads multidisciplinary teams across the Southeast and has consulted nationally on high impact cases, including the Flint water crisis. Dr. Hertza ensures that our team delivers consistent, evidence-based care, especially in complex legal and workers' compensation settings. So with that, I'd like to turn it over to you, Dr. Hertza.
Hello, everybody. First, I'm thrilled to be part of all things Neuro 360. I think we really legitimately offer truly integrated care, right? It's not just comprehensive, it's integrated. And I think that that ends up with a real top-notch product. And Drew, I really appreciate kind of the endeavor of adding technology to traditional treatment in order to maximize, people's recovery. So both you guys, I appreciate you both. All right, I'm going to go ahead here and share this, and we're going to go ahead and get started. We'll see if the technology works. We're hopeful. We'll see. All right, I'm assuming people can hear me and see me. If not, Jen, please text me. All right, I'm going to go ahead and get started here. And so today we're talking about interviewing TBI patients, coming to essential questions and approaches for attorneys. Now, when I sat down to write this lecture, I originally started off by writing all these questions, and you'll see that at the beginning and also at the end of this lecture. But then I thought, instead of just providing people kind of, hey, these are the things you need to ask, I thought, wouldn't it be way more powerful, way more meaningful if you understood why you have to ask these questions? And so that's part of what we'll be talking about today. So as part of that, we need to review concussion. If you guys have seen my lectures before, I will hit on the neurochemical cascade, but the rest of it will be largely new. We're going to review comorbidity that you need to ask about and things that ultimately really do help in understanding what's going on. We're going to talk about what is and what is not consistent with the concussion and what to ask. And again, the goal is not just to know what to ask, but why. But this is fun. So I'm going to be a lawyer today, right? My job is to go through and explain how to ask questions, but also I'm going to give you an argument. And I'm going to give you an argument as to why this approach is needed and why it leads to better outcomes and better understanding of your clients. So let's start off with the questions, right? And you'll see that the ones at the end and the ones at the beginning are mostly the same, but I kept adding them as I was thinking. So I'm happy to pull them all together into something comprehensive that we send out. But we need to understand mechanism of injury. Is there a plausible force that could have actually caused this, right? Now the research does support, we'll talk about this as we go, what forces may or may not cause something, but you have to ask what happened. Next is loss of consciousness versus alteration of consciousness. So you need to ask the patient, the client, did you lose consciousness? Was there alteration of consciousness? Were you confused? Were you disoriented? How long did that last? We're going to talk about retrograde and anterograde amnesia. Retro, which makes sense in the past. You want to ask about that 1 to 2 hours prior to the injury and the 1 to 2 hours after. What happens in trauma is the brain panics and all of its energy is focused on keeping you alive. It's not worried about forming memories, at least not when it comes to facts. It does remember fear responses, but that's a different part of the brain called the amygdala, where like most of our memories of stuff is in the limbic system, the hippocampal areas. Point in telling you all that is that, yeah, you need to ask about memories on either side. Was there airbags? Did they go off? Did an ambulance come? Did you look at ER notes, ambulance notes? Does all this line up? We need to ask about acute neurologic signs, dizziness, nausea, vomiting, vision changes, balance changes, headache. But this isn't just a list. Each one of these lines up with neurologic changes that happen in the brain. Now, sometimes people get in accidents, things happen to them, their adrenaline spikes, they're freaking out, they're worried about their phone, their children, calling their husband, whatever, right? And so they're fine. I don't need an ambulance. I'm good. Get me out of here. And then they wake up the next day and they feel terrible. Why? Because their adrenaline, those systems deactivated, and then these other things were present. You need to ask, was this delayed onset of symptoms? Mood, was there mood issues before? Did they start all of a sudden or did they start over time? And again, I'll explain why each of these is important. Now, and if you're on, if you're defending, the client here, these are questions you'll ask to understand, but don't think each one of these is a point that defense will use to argue against brain injury. So every one of these is set up to really understand what exactly is happening. Is there past concussions or seizures, contributed meds, side effects? A huge one's gabapentin, by the way. It affects white matter and slows processing. Was there ADHD, dyslexia? Sleep issue is a huge issue when it comes to these cases. Was there development of post-traumatic sleep apnea? Were there issues before? Also, are they malingering, right? That's important. Listen, all of us believe our patients. We all take what they say to us. Lawyers, you should believe what people bring to you, but we're also not naive. And the research supports up to 80% of people exaggerate to some level. Of course, that doesn't mean they don't have real things going on. It means this is what it is. There's money involved, there's lawyers involved. So we need to be very aware of those things. And there's things that people tend to malinger, and there's things that they don't. So you have to understand that. I'll give you a great example of that. Um, because of how the brain is designed, true short-term memory loss is inconsistent with concussion. And it is the number one thing people fake is memory loss. What you do have instead is problems with focusing, organizing your thoughts, and processing because they're frontal and white matter tracts. What is the course of symptoms? Is it progressive? I have a case I'm actually going to trial on here in a couple weeks, and the patient's reporting that things keep getting worse, keep getting worse, keep getting worse, consistent with concussion. But he's 68 years old. It could be consistent with Alzheimer's. So I got to figure that out, right? I got to figure out what's due to what and understand these things. Do symptoms match the literature? Does it match the biomechanical forces? Does it pass the smell test? Is something fishy when you're sitting there with somebody? And what is the confluence of data support? Super important. At this point in time, there is no one test for concussion. There doesn't exist. So what you do is you take all this different research and these different things that are coming together and you pull it all together. And then that lets you know what's going on. That's what paints the picture. But that's good medicine in general, right? Like good medicine is integrating all the data in order to make a decision, not just making it on one piece of data. And that's what needs to happen here. All right, let's do it. Let's help us understand why these are the questions that we need to ask. And I do apologize. I will move quick through some of this because we have a lot to discuss. So mild TBI, concussion, minor head injury, post-concussive syndrome, all this stuff is the same thing. So it's important you understand there's a variety of descriptions that people use. Now, just because an MRI is negative, a CT is negative, it literally means nothing other than the TBI is mild. So absence of evidence is not evidence of absence, and that's important that you know. Concussion, less than 6 hours, alteration of consciousness. That's why you asked about it. Did it happen? Notice it doesn't say loss of consciousness because the alteration is significant enough. And that happens because of disruption to the reticular activating system. Now, your brain looks like a mushroom inside, the wires. They run up like a stalk and they fan out to the sides. When that stalk gets messed up, and I have a slide of that I'll show you in a minute, well, then this is what causes a concussion, it causes the loss of consciousness. And again, you could be awake and dazed, and you need to look at that retrograde and anterograde amnesia that we talked about. And almost all patients in mild TBI have normal CT and MRI. There are 5% that have hemorrhage, and that's called that's a more of a complicated case. And now they also have a normal range Glasgow Coma scale, 13 to 15, also important. Now, 80, 90% of concussions, 14 days, they're resolved. Why? Because that's how the brain chemistry changes over time. So as you're sitting there with your patient and you're sitting there with the client, you need to decide, okay, when did the accident occur? What changed over those first 14 days? The 14 days is critical because that is like the cycle of resetting yourself afterwards. And then what lasted. And the research can tell you what's likely to happen and how this matches it up. So let's say 5% of people have symptoms that last more than a year. The truth is, if you still have symptoms at 3 months, you're probably gonna keep having it, right? So that 3 month marker is pretty important. Now, the outcomes in kids and athletes is actually better. In athletes in particular, almost everyone recovers, and we're not really sure why. Although the studies based on that were predominantly in children, they were not in adults, and that's interesting because there's principles out there that understands that the child's brain is more malleable, right? And personally, I think there is the literature is complicated because repeated head injuries, repeated concussions do lead to long-term issues in athletes. So again, it matters kind of what's happening. And are there some people that are more likely to have problems? Of course. The research supports middle-aged women, and there's a number of things, including premorbid depression, emotional distress, and so on. So, and this happened recently in a trial. I was asked, well, why do you think this person is one of the 5%? Well, actually, if you look at the research, of that 5%, most of those people line up with what we're seeing here with our patient, right? So it's not they're one of the 5% of that group. They're actually pretty likely to have these lasting deficits. Now, we talk about this kind of stuff. About 38% still report kind of some things at 6 weeks. And that's why I said that 3 month window is really important. Now, that doesn't mean that 38% still have neurologic change. It means they're still reporting symptoms. And 28% at 6 months. Now, there's categories you need to ask about, and these are listed here for you. The first is predominantly neurological, headache, dizziness, malaise, fatigue, so on. The second is more emotional, irritability, depression, anxiety. The third is more neuropsychological, neurocognitive. And then again, we highlight sleep. Uh, I can't state that enough how important it is to evaluate sleep and ask about it. If you have somebody that's sleeping 2 hours a night and they say they can't focus or remember anything, of course they can't, right? You can't jump to a conclusion and think all this is due to TBI because maybe it is, maybe it isn't. Reduced alcohol tolerance is absolutely noted in concussion. So it's important you ask about these things. And how preoccupied are they? Do they have fear of brain damage? Like, what is their thoughts on this? So here's your common symptoms, right? And I told you I'm moving quick, and I'll probably pick up speed as we go. But headaches, depression, fatigue, visual disturbance, memory loss, attention issues, and these are actually the diagnostic criteria that go into TBI. So again, very important to go through. I will say that the definition of what TBI looks like. Mild neurocognitive disorder, major neurocognitive disorder is currently being evaluated, and there are programs out there. Actually, there's think tanks out there that have evolving definitions of these things because technology is changing so fast. Truly, it's any transient neurological dysfunction caused from a biomechanical force. That one I like because there's a lot that can fall underneath that. Again, usually recovers over time, and that suggests that there's some temporary neuronal dysfunction, not cell death. But if there's permanent problems, there's probably is some level of cell death. And that's where things like DTI and other things could potentially be helpful. Now, as soon as you have the injury, you have a release of neurotransmitters. You have changes in levels of ion fluxes. And that's what causes each one of those things I told you to ask about in your interview. You're not just asking this because, oh, well, it sounds like a good idea. Most people reported these things. No, you're asking these because these are the symptoms that happen because of neurochemical changes in the brain. Again, going back to why we ask what we do. Now, when that neurochemical cascade hits, there's significant changes in cerebral glucose metabolism, how your brain feeds, right? And that's because the energy is going to the rest of the body to keep you alive. Now, the neurochemical cascade occurs even in completely normal GCS scores, Glasgow Coma Scale scores. It could be 13 to 15, and this still happens. And that highlights that a GCS score, or even like a Rancho Los Amigos score, those things are not the end-all be-all at all. So it really underscores the need that we got to look into this. We got to understand how all these things pull together. So I want to go through the steps real quick. This is something that may be a little repetitive if you've heard my lectures before, but I'm going to kind of tie this together as we go. So step one, you get your head shook, something happens. You have an immediate abrupt neuronal depolarization and it drops. That causes the brain to freak out because it went too low. So it releases all this excitatory neurotransmitters, including glutamate, which is the number one excitatory neurotransmitter in the brain, calcium, different things. That then overcorrects again. The ion starts to shift. That changes blood flow and metabolism, and that ultimately impairs your axons. So these are the steps. This is what happens. Normally what happens over that period. Now it's complicated. This shows you how complicated it is. I'm making something complicated simple, but you could see all the different things that are happening at once, right? This isn't just, oh, I got kind of rattled in my head, I'm fine. Like chemistry is changing. And here this shows you over those 14 days or so, research supports 9 to 10, but for general saying, we'll say, I don't know, 10 days, 2 weeks, you can see what happens, right? So here's the glutamate I was talking about, right? Because the brain depolarized too quick and then it overcorrected itself. Here's your cerebral blood flow. You can see on the bottom. And then you can see where that calcium ultimately stabilizes. But not everyone does. Not everyone goes back to normal. Here are each one of those steps I told you, and next to it you will see the exact symptom I told you to ask about. I told you to ask about headache, light and sound sensitivity. Why? Because we're understanding the ion flux. I asked you to talk about processing speed or reaction time. That's directly related to impaired neurotransmission, right? Are symptoms lasting? Are they persistent? I'm asking about protease activation, cell death, altered cytoskeletal proteins. So everything you're asking is for a reason. Things you consider for biomechanical forces, impact velocity, force of impact, right? Concrete floor versus sheet metal versus a swimming pool. Um, Acceleration, deceleration, and that has to do with coup, contra coup, and rotation, angulation. Brain injury is a study of physics and how force impacts different densities across the brain. And as you ask questions to understand what happened to somebody, again, these are kind of what we'll tell you about. Now, you can have anything from a penetrating injury, something gets stuck in your head, to axonal shearing in the wires, kind of twisting. But there's two main categories that happen. Diffuse axonal injury, wires of the brain get screwed up, and bruises, contusions. All right. This is kind of a terrible picture, but the weird checkered stuff in the brainstem, that is the reticular activating system, the stalk of your mushroom. And you can see basically the brain's bouncing around in the skull. Now, you would think if the back of the head has to do with vision issues, right, and the front of the head has to do with attention, that people would really complain of both things. They do, shocking, right? But they will be more likely to have issues on that front part than the back because of how the skull is shaped. And we'll review that here in just a minute. Here's your jiggly brain. You can see it bouncing around, right? All right, kind of looks like Jello, I think. It needs like fruit in there, maybe some, I don't know, grapes. Sorry. So if we look here, we can see, going back to that Jello actually, like let's imagine that you had a bowl of Jello and it was full of fruit. And I always give the example of the horrific Jello they had for me in elementary school with the disgusting, weird, off-colored grapes. If you took that thing and you shook it, what you'd find is that the fruit would move, the Jello wouldn't, and there'd be tracks where the fruit moved. Why? Because the fruit, the Jello are different densities. So in the brain, the different parts of the axons of the wires, they slide, and that results in twisting and shearing. And you can see that here in the bottom. So here's the brain. These are the wires. And here's the stalk, the reticular activating system right next to the medulla and the pons. And so the higher speed you have, the higher acceleration, deceleration, the more force that goes into it. I had a case not long ago where a woman didn't get hard, but she got hit by a bus. So all that force still got pushed into her, right? And you could calculate these things. And the white matter tracts can stretch and they could have disconnection syndromes to different parts of the brain. And this is the beginning of the neurochemical cascade. So here's just some example, like when you talk about death in brain injury, it's almost always due to diffuse axonal injury, and we can see that on DTI and some other things. And you can see here, you can see the white matter damage, the white spots, right? And those are the wires that have been torn. So here's your brainstem, right? And you can see what happens. You have a steep belt across your chest, So it's holding your chest in place, but there's nothing holding your head, right? I did see on Facebook the other day, it was showing me like a seatbelt from like the 50s or whatever, and it just wrapped around your neck. So that might make sense here, but I think generally a terrible idea. But here what happens is your chest doesn't move, but your head still does, and your brain still does. So you can have shearing through here, and that could alter the communication from the brain to the body. So looking at the skull, here's the ridges I talked about. That's the cribriform plate. Here's the temporal poles. Here's the back of the occipital lobe. And we need to understand the different parts of the brain. We need to understand functional neuroanatomy. And I'm going to give you a brief lesson in functional neuroanatomy. And I don't know, it'll probably take me, I think, about 8 minutes to do it. But it's important because then that makes you understand, well, this is what I have to ask about. This is what I have to follow up with. The part of the brain that sits on these ridges right here, and if you remember to the jello when the brain's sloshing back and forth, it would rub against this, right? This is called the orbital frontal cortex, the part of the brain that sits on it. And they're very clear neuropsychological, neuropsychiatric correlates with damage to those areas. Similarly, the anterior temporal cortex sits here where these temporal poles, like these bones are right here. And this has to do with emotional control, right? So again, like we have to understand these things. And here's how the brain sits in the skull. And you could see right here how it would grind up against here, right? And the vision and olfactory tracts run through here. So you can have changes in smell and vision and perception all in here, right? And recently in the last couple of years, there's been some really wonderful vision tests that have come out that track how the eyes respond to movement. And the reason that works is because this is the area that's most sensitive to damage, and we're measuring how the tracks run in through here and their effectiveness at coordinating everything. And that pattern can help us understand kind of what's due to what. So that's why the research works. And again, you're looking at all the different data points, the neuropsych data, the vision tests, imaging, all this stuff together to help understand what's happening because there is no one solution. There's a combined solution. Now, this is what happens when things go bad, right? But if you look at it, there's something really fascinating here. And that's that the front lobe and the temporal poles are basically gone. This person did die. But the back of the brain, not this part of the brainstem, but the back of the brain's fine. And that is because of the smoothness, right? Um, Vision problems due to occipital damage are really unlikely in concussion, right? It's not that vision problems are unlikely. Vision problems due to occipital damage are unlikely. It has to do more with the parietal lobes. And you can also have something called vertical diaphoria. And that's where the images, instead of, they aren't lining up this way. Now, most of the time when you need like a prism glasses or something like that, they're integrating images this way. But in brain injury, it's different. And sometimes we have problems lining things up this way, and that'll lead to headaches and other things. And again, here we go, right? Comprehensive evaluation. Here's the part of the brain that sits on those areas I was telling you about. And in particular, the orbital frontal lobe right here, the most sensitive part, has to do with our ability to control our emotions, stay focused, multitask, right? Control our irritability, find our words. Like these are the things people say to us. These are the things people convey to us when they come to us and tell us we're having problems, and it makes sense. So you are going to behavioral control. You're going to ask questions about ability to multitask and stay focused because you know that this part of the brain is most sensitive to damage. Now, neuroanatomy is important. We can predict impairments and challenges. We can validate patient report, and test data can line all this up so we understand what's happening. This is physics, again, and how all this works. So today we're going to talk about only frontal and temporal lobes because, I once had to do a functional anatomy course and it was 19 hours long. And it went through all the ascending, descending tracts and cranial nerves. But today we're just going to have like a 5-minute hyper focus on the parts of the brain most sensitive to damage because these are the areas you have to ask about as lawyers, as doctors, as clinicians. So frontal lobes, we're going to talk about that because that's the area that's most sensitive. And ultimately, deficits are quite varied, and there isn't a single syndrome. Understand, and this is super important when we talk about post-concussion, a syndrome is not a disease. It's a collection of symptoms. So post-concussive symptoms are not the same as diagnosing a mild TBI, right? So understand the difference between these things as we use it. Now, The location of frontal lobe injury can result in significant differences. I'll give you a great example. In school, I was asked, this is pretty morbid, by the way, but I was asked, okay, Jeremy, we need you, the rest of the class, you're going to write a paper. You got in this horrific accident, and part of your brain is missing. I want you to write what part of the brain you picked and what it would do to you. It's pretty morbid, but I picked the right frontal area. Why? Because if you get damage to this area, one, you're going to have very little appreciation of your problems. You're like, oh, I'm fine. Two, you're going to be pretty disinhibited. So I'm going to be out there super impulsive, having an absolutely great time, having no clue what's wrong with me. Bring it on, right? So, but if I had had damage to the other side, I would have actually had an agitated depression. I would have perceived my deficits potentially as more significant than they are. This is physics. Which side were they on? Were they a passenger and they hit the door on the right side? Were they driving and hit the left? You need to ask and you need to know because it helps you understand what's real and what's not. And knowing these differences is super helpful to understanding disposition, treatment, knowing what to do. And frontal lobe damage often causes problems with comportment. And that's the process of controlling our behavior, controlling our impulses. And for all of us that have been doing this work for a while, we all know that TBIs, we talk about a TBI being frontal, and that means somebody that's impulsive, that's disorganized, that struggles to focus, has poor social emotional awareness. Interesting about frontal lobe damage, IQ doesn't change. How you use it changes. How you use it changes. So you have three major parts to the frontal lobe, and two in particular are more likely to get damaged in a mild TBI. So orbital frontal we talked about, dorsolateral frontal, like a dorsal fin to the side, and then medial frontal, which is deep inside. This is less likely to get impacted, the medial frontal in TBI, well, mild TBI. But if it is impacted, it's very significant where there's a real lack of motivation, initiative, and even go so far to develop total mutism. So people don't speak, they just kind of sit there, they're just not really engaged. Um, anyway, so the orbital frontal part, and again, if we go back here real quick, orbital frontal, right? Let's go, here we go. That has to do with controlling our affect, disinhibition, impaired judgment, insight, distractibility. But it also leads, and I'm going to hit this in a minute, it can lead to acquired sociopathy, antisocial behavior disorder, intermittent explosive disorder. Why did I add that in there? Because all mental health disorders and psychiatric disorders are neurological. They're all from changes that are going on in the brain, right? And so brain damage can cause what looks like a psych condition, but it's due to brain damage versus other things because it's the same organ, the same organ. That's pretty interesting because, and we're going to get to this in a minute, but patients with long-term depression, the research shows they actually have changes in the brain. Patients with chronic PTSD have changes to the brain. So now let's say you got somebody and I don't know, let's hope this doesn't happen, but they had some type of abuse as a child. They had some PTSD from it. They've been dealing with depression for most of their life. They have ADHD. Now they get in this terrible car accident. I'm 100% sure everyone on this call today, on this lecture, has run into that because all the time, right? All the time you run into that. And you run into that for multiple reasons. One is that there are certain people that are more likely to get a concussion, and that falls within that category. And two, that these are similar symptoms that people have. So if this is true, then PTSD, the person went into it with already some brain damage from PTSD. They went into this car accident with already some brain damage from long-term depression. The frontal lobe wasn't working right to begin with because they had ADHD. So what, we're shocked that it didn't take a lot for them to totally unravel? So instead of arguing, oh, it's this versus this, people come to us with their life, their medical conditions, their medications, right? No, nothing's clean. Life is hard. And so they come to us with all these things, and then this happens to them. So understanding it all is key, and that's why you have to ask these questions about past and about what's going on now. Now, the dorsolateral frontal, that's the dorsal fin to the sides. That has more to do with multitasking, coming up with words. Are they repeating themselves? And of course, when you do these type of things, you get a collateral. You talk to a spouse, you talk to a friend, you make sure that what the person's telling you matches up. And they will tell you, yeah, they keep saying the same thing. They can't find their words. They're really a jerk, whatever it might be. If you have damage deeper, this is where we talk about more paresis, apathy, and persistence, really moderate to severe TBI. Switching to the temporal lobes, again, those are on the sides. They have a lot to do with emotional and cognitive kind of functions, and it's really varied in what they do. Deeper inside, they have to do with more memory. In the limbic system, that has to do with olfaction, memory, negative emotions, and so on. But there's 8 principles: auditory sensation and perception, selective attention, auditory visual input, visual perception. That's key because you can have, you can have problems with vision. We talked about that earlier. It's just less likely to be occipital based, but it can be temporal lobe based because of how the brain's organized. And you can have impaired organization and category of material, language comprehension could be messed up, memory we just talked about, personality changes, altered sexual behavior. Can also result in anxiety, aggression, even schizophrenic type symptoms. Fine. So we know we got to understand the brain. We know that we're asking certain questions because certain parts are more likely to be injured. Okay. Now, are there some people that are more likely to go through these things? And what do we need to ask about for those things? Certainly psych disorders, and we need to understand that after an injury and before. Now, a psych disorder can occur immediately after or decades later. That is super important. After traumatic brain injury, mild, moderate, or severe, you have a drastically increased likelihood of developing depression, anxiety, and so on for the rest of your life, even if you had no symptoms for those first 6 months after, because your brain is permanently changed. Now, psychiatric disturbance is common in TBI and mild TBI, and they almost always involve some type of emotional or behavioral component. About 10 to 31% experience physical mood symptoms, and these symptoms certainly can be devastating. Remember before I told you, all of this is the same organ, same brain, right? Now, if we understand normal psychological psychiatric illness and how those affect the brain, it kind of all starts to fit together. Examples: schizophrenia. They have moderate impairments in attention, working memory, language, executive functioning. And actually, on images, the ventricles are larger and the memory centers are smaller. Obsessive compulsive disorder is in the frontal lobe, particularly the orbital frontal area. ADHD has a hypometabolism of the frontal lobe, decreased interconnections, decreased cortical volume in that area. Psychological conditions are neurological. Now, let's talk a little bit, and I'm going to run through the rest here in about 5 minutes and give some time for questions. But we want to talk a little bit about prevalence of psych disorders prior to brain injury. So personality disorders were diagnosed in 24% of this one sample, particularly like obsessive compulsive, antisocial. Individuals without any type of emotional disturbance beforehand were actually more likely to develop long-term problems. Wait a minute, that's kind of weird. Think about it. Why? Why is it that someone that had severe depression before the accident is less likely to have a bad outcome than someone who didn't? Because they already were on meds, they already had a therapist, how to deal with some mood issues. So they actually tend to be a little bit more resilient. The effect of the brain could be greater, but long-term outcomes aren't as affected. Now, rates of resolution in TBI are similar regardless of psych history, right? So you got to stick that in your brain and keep it in there. But people with pre-TBI, major depressive disorder, and substance use disorder are more likely to improve for those reasons we talked about. But the psychosocial outcome can be different. So, are some people more likely to get concussions? Yes. Again, that came up in trial about a month ago. People with ADHD, substance use, bipolar disorders, antisocial, borderline, histrionic. So you can't be surprised when people come to you and have these things because it's probably going to happen. So ignoring it or not doing a deep dive into it, that's on you, right? That is your risk to your case. Depression is extremely common, as much to 12 to 77%. Now, why is that range so great? Because it depends if you're looking at depressive symptoms versus meeting full criteria of a major depressive disorder. Frankly, I think the point to walk away is probably about half end up with some type of depression. And that's super reasonable, right? But it tends to be an anxious, kind of depressed mix, like an agitated, depressed mix. It's not likely that people are anxious and not depressed. It tends to be kind of this mix. Now, Neurologically, after brain injury, there's actually some research that talks about why. Why do people in brain injury have this type of depression? And is it different neurologically? And therefore, the treatment could potentially be different. So, at a theoretical level, the neurocircuits potentially have been disrupted in the prefrontal cortex. We talked about that. The amygdala, which is the fear kind of response, the hippocampus, that has to do with forming new memories, the basal ganglia, automatic motor programming, the thalamus, which integrates sensory information, that all this together, this circuit, is disrupted, particularly the hypothalamic pituitary adrenal axis, where these things pull together. And there's a monoaminergic hypothesis of depression, and that has to do with low levels of serotonin, which then impact inhibition, emotional changes, and so on, directly related to the brain injury because the parts that are involved affect serotonin, right? Also, they can affect glutamate, talked about that earlier, as a excitatory neurotransmitter, and dopamine. Anxiety after brain injury, again, figure around half, right? About 50%. Here's some of the interesting literature I mentioned earlier, that you are 1.7 to 9 times more likely to have generalizing anxiety disorder for the rest of your life. For the rest of your life. Think about that when it comes to life care planning. Think about that. Panic disorder, 2% to 3.3%. Obsessive compulsive disorder, that ends roughly around 10%. Now, symptoms of PTSD, particularly anxiety, depression, all this stuff together ends up being far worse outcomes. So if someone has a TBI and PTSD, the outcomes are far worse because it's double brain damage. I just told you PTSD is neurobiological. Mild TBI is neurobiological. They actually affect different but adjacent parts of the brain. So the two together, worse outcomes. Bipolar disorder, 5.3 times more likely to develop this after mild TBI. Um, really interesting research came out in 2018 that said 1 in 10 diagnosed with bipolar have actually experienced maybe some type of mild TBI, really highlighting that there's a relationship there. Now, schizophrenia is less. Why? Because schizophrenics in generally aren't out there driving, getting car accidents. So you actually are probably not going to run into that. You'll run into bipolar. You're probably not going to run into schizophrenic. And certainly substance use is high both before and after. After brain injury, 3 times more likely. ADHD is incredibly common, and there's a variety of research I presented here that you could look at. Same thing with personality disorders. But what I'm really highlighting is instead of just avoiding all the baggage people bring to you, you need to deep dive it because it all connects together to help know exactly what's real in these cases, which then dictates everything from life care planning to treatment and frankly prognosis. With those frontal and temporal lobe damages, you could have aggressiveness, impulsivity, and so on. All right. Aggression, about 30% of individuals have verbal outbursts and things like that. And it can be very much related to damage to the frontal lobe. Psychosis, less common, far more likely to happen in males, and it tends to be more moderate to severe TBI. Psychosis is not generally seen, in mild TBI, but if you do see it, there's likely a very long loss of consciousness because of how it impacts the brain. So somebody comes to you and they say, hey, I'm having all these hallucinations, probably not brain injury, something else is going on. There's lots of factors that you have to consider that impact things. Sleep. Are they having problems falling asleep, staying asleep? Are they having nightmares? Is there sleep apnea? How many hours do you sleep? What medications are you on? Do you have pain? Do you have headaches? Medical history. Are there vascular issues? High blood pressure, high cholesterol. Huge one is thyroid, hypothyroidism, right? History of urinary tract infections. Was their mood past or present? History of abuse. Did they have ADHD? A tip for everyone. Ask the same question in different ways. And if the patient pauses for a second, ask why. If you say, is there a history of physical or sexual abuse? And they just sit there and look at you for a second and like, well, no, there is. You ask the question differently. You really paused. What were you thinking about? So you need to read the room and respond to people in order to understand what's real because frankly, it's very common that patients won't disclose certain things about their past because they're afraid it's going to mess up their case. Now, they're not lawyers. They have no clue. And they're not doctors. They don't understand that actually what you need to do is be honest about everything so that we can understand what's real, defend you, support you, get you help, and represent you in court. There are some factors you need to consider that are confounding. Remedial factors, medications, mood, motivation, quality of sleep. Fixed factors, nature of underlying pathology, and comorbid conditions, depression, and so on. Some biases you need to watch out for are self-report bias. Self-report is generally not a reliable basis for estimation of pre-injury cognitive status. That's important because the only field that looks at premorbid intellect is neuropsychology. No one else does it because no one else has the tools to look at it, right? But you have to understand what somebody was like before and where they're at now. And the lack of reliability or in self-report has been documented in cases all over the place. Also, this idea of the good old day bias. Everything was great before. So again, our goal is not just to know what to ask, but why you have to ask it. So quickly, I'm going to review again kind of the questions you need to highlight, and then we'll open it up for questions and wrap up. So again, mechanism of injury. Is there plausible force? Loss of consciousness versus alteration of consciousness, retrograde, anterograde amnesia, airbags, ambulance, so on, anyone else in the car, acute neurologic signs, how they felt the next day, mood, past concussions or seizures, medical history, ADHD, dyslexia, sleep. What type of cognitive impairment? Is it progressive? Do the symptoms match the literature? Do they match the biomechanical forces? Does this make sense? What are my biases? And don't ask leading questions. Don't say, do you have this problem? They're like, yep. Do you have this problem? Yep. Do you have this one? Yep. Instead, can you tell me some of the ways that you're struggling? And watch for inconsistencies in patient report. So to pull this all back, and then I'm wrapping up here, I have like 30 seconds. There's a number of questions. Those are listed on the front and the end of this lecture, but you need to understand why you're asking them because that helps you understand your case as a doctor or as a treating provider. And as a lawyer, it helps you know what's real and what's not and helps you able to defend that client, that patient to the best of your ability. I'm going to go ahead and close this here and end sharing, and then I can open it up for questions for everybody. All right, heading back to you, Jen.
Awesome. So I'll just start with Kristen's question on the side, and then if anyone else has a question that you didn't put in the chat, feel free to unmute yourself. So Kristen asked, did you say 5 times more likely to develop bipolar disorder after TBI or 5 times more likely to suffer a TBI if they have a diagnosis of bipolar?
5 times more likely to develop it after a mild TBI. And the research says 1 to 5, so take it with a grain of salt. I think the spirit of it is that a TBI changes neural circuits, and those change of neural circuits can lead to a lot of changes in like how you control your mood and how you control yourself. So to be real with you, a lot of brain injury cases end up with psych diagnoses because they meet criteria, but it's actually not truly bipolar, it's brain damage. It's not truly generalized anxiety disorder, it's brain damage. But that doesn't matter because it's the same brain, it's the same organ. And that's why today, as we discuss things, I wanted you to understand how it's all the same organ. It's weird because, cardiology, that all they do is the heart. But somehow in the brain, you have neurology who does part of it, psychiatry that does part of it. And there's like 3 people out there that do both. So anyway, next question, please. I hope that was helpful.
That was helpful. Let's see. We have one more in there.
Take snide remarks. I know that I look like I'm in an IKEA showroom. Sorry.
I was wondering because I know that pre-existing concussions is a big deal, but how closely together they are is also super significant. So, is it worse to have multiple concussions over a lifetime that would cause bigger impact, or is it how closely together they might have happened and maybe they didn't have it in the past?
There's 2 factors there to consider. One, the severity. So when I ask somebody if they had any past concussions and they say yes, I want to know, was there true loss of consciousness? I generally, a lot of the questions that I do regarding a primary concussion, and I want to know, was there any lasting cognitive changes? And I'll ask the spouse or somebody else too, because if there was no permanent change in any capacity, then it can affect it a little, but it's not a major issue. Okay. That said, If you have 2 concussions within the neurochemical cascade loop within those first 9 days, that's the second impact syndrome. And they could be extremely mild, but your brain never reset before you got another one. Now you got damage. So if it's in the past, it has more to do with symptom severity. If it's in the present, it has more to do, did it occur during the period of neurochemical cascade?
That makes sense. Another question I had was, these are all great questions for the attorneys to be asking right at the beginning, or medical providers. At what point does it make more sense for them to send it to you to do more of a deep dive with your neuropsych evaluation? And would it be at the end of the case or closer to the beginning to get as much data as possible about what's going on?
So if I get a case relatively early on, right, then I'm going to be looking at saying, hey, where are we? And I'm going to run this thing like a treatment plan. So just like I do for the hospitals I work at, I'm on the rehab unit. I do brain injury day in and day out. I'm going to do an assessment. This is where they're at. I'm going to make sure that there's evidence-based treatment that's involved. And then I'll follow up in 4 months after a course of treatment to see, have we reached maximum medical improvement? Are we continuing to recover? So in that case, I am treating and managing the case to maximize the patient outcome, but also to ensure that I've been involved and understand it from day one. The other thing that says is, okay, this person came to me, they've been through some treatment, they've had this stuff going on. I'm not really sure what's what. I need someone to look at all this thing and make sense of it. And I can come in at that point and kind of figure it out. If you're looking for an understanding of what's permanent and static, right? Like I said before, you're going to have a pretty solid idea 3 to 6 months out, right? But assessing them during those first 14 days, that's totally fine if I'm making decisions whether an athlete can go back, right? But they can go back like in a football game. It's not that helpful in terms of understanding long-term sequela. I think that made sense, kind of.
Yep.
But a general rule of thumb is like, look, it's super complicated. There's 1,000 factors that go in there. You can't ignore any of them. So if you want someone to look at it all and tell you what's real and what's not and come up with a plan, I'm happy to do that.
If anyone else has any questions, we have 5 minutes left.
No way.
Don't
I'm,
be
I'm
shy.
early. It's weird.
No, it's no bad question. I know. Don't get the hint that you need to talk longer.
Oh.
I'm just joking.
All right, everybody. So we're going to keep doing this, as Jen said, and she'll give like a wrap up and a review of kind of the things that we offer. But I really want you to walk away from this saying to yourself, okay, this isn't simple. This stuff's complicated. We have to do the right treatment. We have to have all these different data points that pull together to understand what's happening. We cannot ignore the past or things that complicate the case. We need to own them, understand them, or it's super hard to defend and it's hard to write the right treatment plans. So I appreciate everyone and I'll see you in a month. Jen, I'm going to turn this over to you.
Yes. Thank you, everyone. If you need to connect with us in any way, you had Dr. Hertz's information, and then this is also mine. And before we go, just want to put in a plug that next month we will be having Jim Mathis speak to us about PTSD and how to maximize case value. He's an absolute expert on coding and working with insurance, being able to, he's been doing this for over 25 years. So I'm really excited about having him come in. And then very excited about our upcoming trauma conference in October at the Omni Hotel in the Battery. This is a nationwide event where speakers across the country are coming in who are experts on both the medical and the legal side. So save the date. And if you are able to attend, we would love to have you. The link to do that is just at our website, allthingsneuro.com/conference. And we'll be sending out some emails if you haven't already gotten them. But please, please, please mark that on your calendar and join us next month for our webinar. So with that, I want to thank everyone for coming. Thank you, Drew from Harvard MedTech, for sponsoring. And thank you all for taking the time to be here today. Have a great rest of your day. Bye.
Thanks, everyone.